Okay, so we've all been there, right? You're
Yeah.
maybe relaxing on the sofa, finally kick back, and then, the phone rings, or you suddenly remember something in the kitchen, you jump up fast, maybe too fast, and boom, suddenly world goes a bit gray, maybe fuzzy, that crazy head rush feeling that just hits you.
Yeah.
And you find yourself reaching for the wall or a chair just to, stay standing.
Right. And that exact feeling, the one we usually just brush off like, oh, stood up too quickly, it's actually often a sign of something quite specific happening inside. Let's say, failure in your body's own plumbing system, if you will. So today, we're going to move past just calling it woozy. We're doing a deep dive into orthostatic hypotension. OH for short.
Okay, OH. And our goal here is to really get under the hood, understand the nuts and bolts of what's happening. What is it really? Why does this pretty vital system sometimes, break down? And most importantly, why dealing with it is about more than just, not feeling dizzy for a second. Because it really boils down to gravity, doesn't it? You stand up.
Exactly. Gravity pulls blood downwards. We're talking maybe half a liter, a pint of blood, suddenly shifting down into your legs and abdomen.
Wow, that much.
Yeah. And if your body doesn't counteract that pull, immediately, your brain isn't getting enough oxygenated blood. And our sources are really clear on this. For older adults especially, this isn't just a minor inconvenience, it's a serious warning sign. Unchecked OH, it really ramps up the risk of bad falls, fractures. It can even contribute to cognitive issues. And unfortunately, it's linked to higher mortality overall. It's definitely something we need to pay attention to.
Okay, so let's nail down the specifics then. Everyone feels something when they stand up fast, that little adjustment.
Yeah.
So what makes it orthostatic hypotension? Where's the line between normal and a clinical problem? What are the numbers?
That's a great question, and the clinical criteria are very precise. It really separates that everyday head rush from a diagnosable condition. Orthostatic hypotension is defined by a measurable, significant drop in blood pressure upon standing.
Okay, measurable how? Give us the metrics.
So, it's defined as a drop in your systolic blood pressure. That's the top number, right? The pressure when your heart beats a drop of at least 20 millimeters of mercury, 20 millimeters of mercury, 20 millimeters of mercury.
20.
Or, alternatively, it could be the diastolic pressure, that's the bottom number, pressure between beats dropping by at least 10 millimeter Hg.
So 20 systolic or 10 diastolic, that feels like a pretty clear threshold. It's not tiny.
No, it's significant. And crucially, this drop needs to happen within 3 minutes of changing posture. So going from sitting or lying down to standing up.
Within 3 minutes. Why that time frame?
Well, because that's really the critical window where your body should be making its fastest adjustments to counteract gravity. If your pressure drops by those amounts in that time, it means the system isn't responding adequately. That's OH.
Okay, so the failure point is that specific drop. But what's supposed to happen? What's the body's, intended plan? I sort of always imagined it was just the body being slow, needing a moment to catch up. But you're saying there are actual systems designed to prevent this, like internal pressure police.
Pressure police is a good way to put it. Yes, there's a sophisticated system. We're talking about baroreceptors. These are tiny, really elegant pressure sensors, mostly found in your major arteries, like the carotid arteries in your neck and the aorta near your heart. Think of them as super-sensitive monitors in your body's internal hydraulic system. The second you start to stand,
They sense the pressure dip.
instantly, they detect that immediate pressure drop caused by gravity pulling blood down, away from your head.
And they need to react, like yesterday.
Oh, absolutely. Within milliseconds, these sensors send a signal straight to your brainstem, and the brainstem then tells your autonomic nervous system, think of it as your body's automatic pilot, to trigger 3 key responses, all coordinated to push that blood back up.
Okay, 3 things need to happen fast. Let's break those down. What are they?
Okay, step 1. Your heart rate has to speed up, quickly. It's like cranking up the power on the main pump. Step 2. Your peripheral blood vessels, especially the ones down in your legs and abdomen, they need to constrict, to tighten up. Imagine squeezing a hose pipe. The pressure inside increases, right? It pushes the water flow upwards. Same idea here. Constriction limits the space for blood to just pool down there.
Right, pushes it back up. And the third step, you mentioned it involves movement.
Yes, it does. The third step involves what we call the muscle pump. When you stand and tense your leg muscles, even slightly, those muscles contract and physically squeeze the veins. This helps push that pooled blood back up towards your heart. So you see, OH isn't just about a weak heart or leaky vessels. It's often a failure of timing and coordination in this whole response.
Oh, okay.
If that autonomic response, the heart speeding up, vessels tightening, muscles pumping if it's too slow or not strong enough or just doesn't happen properly, then the blood stays pooled down low, less oxygen gets to the brain, and that's when you get the dizziness, the lightheadedness, the whole world tilting feeling.
That makes so much sense now. It's a system failure, not just a slow moment.
Ah.
Okay, let's unpack why it fails then. If this baroreceptor system is so clever, why does it just not work for some people, or sometimes? What causes Plan A to fall apart?
That really is the crucial question. And the reasons, based on our sources, they fall into a few main categories. Some are complex medical conditions. Others are surprisingly simple, almost environmental factors.
Okay, where do we start? What's a common reason for this system to go haywire?
Well, a big one is what's called autonomic nervous system dysfunction, or ANS dysfunction. Remember, the baroreceptors are the sensors, but the ANS is like the wiring that carries the signals to make things happen, telling the heart to speed up, the vessels to tighten. If diseases damage these nerves, the wiring gets faulty.
And what kind of diseases are we talking about?
Diabetes is a really significant one. Over time, high blood sugar can damage nerves throughout the body, including these crucial autonomic nerves. It's part of diabetic neuropathy. We also see it often linked with neurodegenerative conditions, things like Parkinson's disease, or a related condition called multiple system atrophy. In these cases, the nerve signals are just too weak or too slow.
Got it. So, bad wiring, the fix doesn't get triggered properly, but you said sometimes it's simpler, more mechanical, like
Yeah.
maybe just being dehydrated. Could that do it?
Yeah.
Lying on the couch all afternoon with just one coffee? Maybe that sets you up for a fall, literally.
Oh, absolutely. Dehydration is a very common culprit. It's basic fluid dynamics, really. If you're dehydrated, you simply have less fluid volume circulating in your blood vessels. Lower volume means lower pressure to begin with. So even if your nerves fire perfectly and your vessels constrict like they should, there just isn't enough fluid volume to push effectively against gravity all the way up to your head. Simple cause, often simple fix, drink more water.
Right. Simple but critical.
Yeah.
Then there are medications. Lots of people take medications for various things, and sometimes these can mess with this pressure system, right?
Yes, medications are a huge factor. Think about drugs for high blood pressure antihypertensives. They're designed to lower your blood pressure, which is usually good, but if they lower it too much or prevent it from rising quickly when you stand, that's a problem. Diuretics or water pills, they reduce your body's fluid volume, which, as we just said, can lead to OH. Also, certain types of antidepressants, and somewhat ironically, even some medications used to treat Parkinson's disease, can interfere with the chemical signals the ANS uses.
Wow, so managing medications becomes really key. What about things that seem almost unavoidable, like just getting older or being less mobile for a while?
They're definitely linked. Prolonged bed rest, say after surgery or during a long illness, it deconditions your whole cardiovascular system. Your baroreceptors become less responsive, less sharp, and aging itself plays a role. As we get older, our blood vessels tend to become a bit stiffer, less elastic. So when the ANS sends that signal, tighten up, the stiffer vessels just don't respond as quickly or effectively as younger, more flexible ones. That delay can be enough to cause symptoms.
Okay, connecting all this, it makes it really clear that OH isn't just about feeling faint for a moment. The stakes are actually quite high. Let's talk about those consequences.
Yeah, the consequences can be serious. The most obvious immediate danger is falling. If you get dizzy enough to lose balance, or worse, actually faint, that's called syncope, you can fall and get badly hurt. For an older person, maybe with weaker bones due to osteoporosis, a fall leading to something like a hip fracture can be devastating for their independence and health.
And that syncope, the fainting itself, is scary. Losing consciousness because your brain isn't getting enough oxygen.
Exactly, but it's not just the acute events, the falls or fainting. We really need to think about the longer-term impact, too. OH means repeated episodes of reduced blood flow, reduced oxygen supply to the brain, even minor episodes. Think about the cumulative effect of that happening day after day, week after week. Over time, this can contribute to chronic fatigue, feeling foggy or confused, and research suggests it can actually speed up cognitive decline.
So managing OH is almost like proactive brain protection.
That's a really good way to put it, yes. And on top of that, for people who already have conditions like, say, heart failure or certain kinds of diabetes, episodes of OH put extra strain on a system that's already working hard. It can make those underlying conditions worse.
Okay, given how serious this can be, how do doctors actually confirm it? We talked about the 2010 rule, but how do they test for it in a clinic?
The standard clinical test involves measuring orthostatic vital signs. Sometimes, if they use a special table, it's called a tilt table test, but the principle is the same. Basically, they'll measure your blood pressure and heart rate while you're lying down comfortably. Let you rest for maybe 3 to 5 minutes to get a stable baseline. Then you stand up, and they'll measure your BP and heart rate again right away and often again after 1 minute and 3 minutes standing. They're specifically looking for that drop 20 systolic or 10 diastolic within that 3-minute window.
Makes sense. Very methodical. Now let's talk about awareness outside the clinic. Our sources mentioned using data from wearables, things like smartwatches, and you're clear these aren't diagnostic tools, but they sound like they can be really helpful for maybe spotting patterns, amplifying awareness.
That's exactly the role. Tools like Finch Q, which use data streams from devices like an Apple Watch, they excel at pattern recognition over time, something a single snapshot in the doctor's office might miss. It's about potentially catching trends that suggest the system is struggling.
Okay, how specifically? How does tracking something like, say, heart rate variability or resting pulse relate to OH risk?
Well, think about it. If your autonomic nervous system is constantly struggling to manage these pressure changes when you stand, your body might compensate in subtle ways, even when you're at rest. For instance, we might see a resting heart rate that's consistently a little higher than expected for that person. It could be the body keeping the engine revved slightly higher all the time, almost anticipating the need to respond quickly to standing.
Ah, that's interesting. The higher resting pulse as a sign of the system working overtime.
It could be, yes. Finch Q also looks at heart rate variability, or HRV. HRV is a really good indicator of how well your ANS is functioning, how flexible and responsive it is. If the ANS is impaired, maybe due to diabetes or another condition, the HRV might be lower than normal. That suggests the system's ability to react quickly is reduced, which could increase the risk for OH.
Okay, so knowing all this, the causes, the risks, how it's measured, what does this all mean for someone experiencing this? We have solutions, right? This isn't something people just have to live with.
Absolutely not. There are definitely actionable strategies, and they generally target the main failure points we discussed: maintaining enough fluid volume and helping the body's mechanics.
So number one is probably hydration, right? Volume, volume, volume.
Cannot emphasize that enough. Staying well hydrated consistently is probably the single most important and often easiest thing you can do. Keep that intravascular volume up. For some people, if their doctor agrees and it's appropriate for them, meaning no heart failure or kidney issues, usually increasing salt intake slightly can help the body hold onto that fluid boosting baseline pressure. But that needs medical guidance.
Right, supervision is key there. And then there's physically helping the body fight gravity.
Exactly. Mechanical assistance, compression stockings, or even better, abdominal binders or waist-high compression garments can be really effective. They literally squeeze the lower body, reducing the space for blood to pool down there, keeping more of it circulating higher up.
And exercise. It seems to have everything, but does it play a specific role here?
It does. Specifically, exercises that strengthen the leg muscles, calf raises, squats, that sort of thing. Stronger leg muscles mean a more effective muscle pump. When those muscles contract as you stand, they give a better squeeze to the veins, actively pushing blood back towards the heart. It assists the whole reflex.
Makes sense. And probably the simplest advice, the one that costs nothing. Just slow down.
Slowing down postural transitions is absolutely crucial. Non-negotiable, really. Get into the habit. Before jumping out of bed, sit up first. Pause on the edge of the bed for, say, 30 seconds. Let your body adjust. Then stand up slowly. Just giving your cardiovascular system those few extra seconds can make all the difference, allowing the burr flex time to kick in more gently.
And circling back to medications, checking in with your doctor about those is vital too.
Essential. If you start noticing symptoms after starting a new drug, or maybe you realize you always feel dizzy an hour after taking a certain pill, talk to your provider. Sometimes it's as simple as adjusting the timing of a dose or maybe trying a different medication in the same class. It requires that conversation.
Okay, finally, let's loop back to the data and awareness part. How does a tool like Finch Q actually help someone, and maybe their doctor, manage OH day to day?
Well, by tracking things over time, not just pulse and HRV, but also activity levels, step count, and even metrics related to walking stability or gait patterns. FinchQ compiles this into a daily score, like the Finch score. It's looking for deviations from your normal baseline. If the system starts noticing, say, your walking steadiness is decreasing slightly, or your activity patterns change in a way that might suggest fatigue or imbalance, these could be early signs of dysregulation, possibly linked to underlying OH, maybe even before a noticeable dizzy spell or a fall happens.
So it's giving you objective data to potentially connect with those subjective feelings of maybe just feeling off.
Exactly. And the system can then provide alerts or insights based on these patterns, not a diagnosis, to be very clear. But it might prompt you, hey, noticing some changes here might be worth discussing with your doctor. It gives both you and your clinician more information, more context. It helps tailor those management strategies we just talked about. Maybe you need more hydration. Maybe it's time to be stricter about compression. Maybe a medication review is due. It supports that personalized management.
So orthostatic hypotension can be subtle, kind of sneaky, definitely widespread, but the good news is it's very manageable. If you understand the basics, the numbers, the mechanics, why it happens, and you use the tools and strategies available, you're definitely on the right track to keeping your pressure stable and staying upright.
Absolutely. And that brings us nicely to a final thought to leave you with. We've talked a lot about the link between OH and reduced blood flow to the brain and how that connects to cognitive issues over time. We tend to focus, understandably, on preventing the big things, the dramatic falls, the frightening fainting spells. But maybe we should also consider the cumulative cost of the small events. What about those frequent, milder head rushes? The ones that make you pause for a second but don't cause a fall? What is the long-term, decades-long impact of those repeated, subtle dips in brain oxygen supply, even if they seem minor at the time? It really makes you think about how important it is to address even mild symptoms, doesn't it? Perhaps that's something worth exploring.